A patient with septic shock has a MAP of 58 mm of mercury after fluids. Which is the next best intervention? A. Administer vasopressors. B. Give more crystalloids only. C. Monitor without intervention. D. Reduce oxygen therapy. Answer: A. Persistent hypotension despite fluids requires vasopressors to maintain adequate MAP and organ perfusion. What is the first-line inotropic agent in cardiogenic shock with low CO? A. Dobutamine. B. Norepinephrine. C. Dopamine. D. Nitroglycerin. Answer: A. Dobutamine increases contractility and cardiac output without excessive vasoconstriction, improving tissue perfusion in cardiogenic shock. Which statement is true about lactate clearance in shock management? A. It is not useful for prognosis. B. Increasing lactate indicates improved perfusion. C. Decreasing lactate suggests effective resuscitation. D. Lactate is unrelated to tissue hypoxia. Answer: C. Lactate clearance reflects improved tissue perfusion and correlates with better outcomes in shock patients. Which hemodynamic pattern is typical of late septic shock? A. High CO, low SVR. B. Low CO, high SVR. C. Low CO, low SVR. D. High CO, high SVR. Answer: B. Late or decompensated septic shock shows low cardiac output and high SVR due to myocardial depression and compensatory vasoconstriction. Which complication is most likely in untreated hypovolemic shock? A. Organ hypoperfusion leading to multi-organ failure. B. Hypertension. C. Bradycardia. D. Hypervolemia. Answer: A. Persistent hypoperfusion causes tissue ischemia and multi-organ failure, emphasizing rapid recognition and intervention. Which monitoring is most important in distributive shock? A. Central venous pressure only. B. MAP, lactate, and urine output. C. ECG only. D. Temperature only. Answer: B. Continuous monitoring of perfusion, MAP, lactate, urine output, guides therapy and early detection of deterioration in distributive shock. Which is a key difference between cardiogenic and obstructive shock? A. Both have low CO. B. Only obstructive shock responds to fluids. C. Cardiogenic shock has low SVR. D. Obstructive shock never causes hypotension. Answer: A. Both shock types feature low cardiac output, but obstructive shock is due to mechanical obstruction, while cardiogenic is due to pump failure. In hypovolemic shock, which heart rate response is expected? A. Bradycardia. B. Tachycardia. C. Normal heart rate. D. Irregularly slow rate. Answer: B. Hypovolemia triggers compensatory tachycardia to maintain cardiac output in the setting of reduced circulating volume. Which parameter best reflects afterload in shock states? A. Stroke volume. B. Systemic vascular resistance, SVR. C. Central venous pressure, CVP. D. Heart rate. Answer: B. SVR reflects the resistance the heart must overcome to eject blood. It is critical in assessing vasodilatory or vasoconstrictive shock. A patient with septic shock is hypotensive despite fluids and norepinephrine. What is the next intervention? A. Add vasopressin. B. Stop norepinephrine. C. Decrease fluids. D. Start diuretics. Answer: A. Vasopressin can be added as a second-line agent to restore vascular tone and maintain MAP when high-dose norepinephrine is insufficient. A patient in hypovolemic shock has a heart rate of 130 bpm, BP 85/60 mmHg, and cold extremities. What is the priority intervention? A. Administer 4 fluids rapidly. B. Give oral fluids. C. Apply a warm blanket only. D. Start diuretics. Answer, A. Hypovolemic shock results from fluid loss. Rapid 4-fluid resuscitation restores circulating volume, improves perfusion, and stabilizes hemodynamics. Which hemodynamic parameter is most indicative of cardiac preload? A. Central venous pressure, CVP. B. Systemic vascular resistance, SVR. C. Cardiac output, CO. D. Pulmonary artery wedge pressure, PAWP. Answer, A. CVP reflects right ventricular preload and guides fluid management. It helps differentiate hypovolemic, distributive, or cardiogenic shock. A patient develops sudden hypotension and tachycardia after chest trauma. Which type of shock is most likely? A. Cardiogenic. B. Obstructive. C. Distributive. D. Neurogenic. Answer, B. Chest trauma can cause obstructive shock, e.g., tension pneumothorax, cardiac tamponade, where impaired ventricular filling reduces cardiac output. Which finding differentiates cardiogenic shock from hypovolemic shock? A. Cold, clammy skin. B. Low blood pressure. C. Elevated PAWP. D. Tachycardia. Answer, C. Cardiogenic shock features elevated PAWP due to left ventricular dysfunction, whereas hypovolemic shock has low filling pressures. What is the main goal of vasoactive therapy in distributive shock? A. Reduce preload. B. Increase afterload and maintain organ perfusion. C. Increase heart rate. D. Decrease oxygen delivery. Answer, B. Distributive shock involves vasodilation. Vasoactive agents, e.g., norepinephrine, increase systemic vascular resistance, maintaining perfusion pressure. A patient has a MAP of 55 mm of mercury despite adequate fluid resuscitation. Which is the best next step? A. Continue fluids only. B. Initiate a vasopressor infusion. C. Start diuretics. D. Position patient supine and wait. Answer, B. Persistent hypotension after fluids indicates need for vasopressors to maintain MAP greater than or equal to 65 mm of mercury and ensure organ perfusion. Which lab value is most sensitive for tissue hypoperfusion in shock? A. Serum potassium. B. Lactate. C. Hemoglobin. D. Sodium. Answer, B. Elevated lactate indicates anaerobic metabolism from inadequate tissue perfusion, making it a sensitive marker of shock severity. In obstructive shock due to pulmonary embolism, what is the expected hemodynamic pattern? A. Low CVP, high CO. B. High CVP, low CO. C. Low SVR, high PAWP. D. Low CVP, high SVR. Answer, B. Pulmonary embolism obstructs right heart outflow, causing elevated CVP and decreased cardiac output. A patient in septic shock shows warm extremities and bounding pulses. Which hemodynamic profile is expected? A. Low CO, high SVR. B. High CO, low SVR. C. Low CO, low SVR. D. High CO, high SVR. Answer, B. Early septic shock often presents with high cardiac output and low systemic vascular resistance due to vasodilation. Which intervention is critical in cardiogenic shock? A. Aggressive fluid resuscitation. B. Inotropic support to improve contractility. C. Administering diuretics only. D. Placing patient in Trendelenburg position. Answer, B. In cardiogenic shock, poor contractility reduces CO, inotropes, e.g., dobutamine, support cardiac output, while excessive fluids can worsen pulmonary edema. During monitoring, a patient has MAP 60 mm of mercury, CO 6 liters per minute, and SVR 700 dyne, SCM. This is consistent with A. Hypovolemic shock. B. Distributive shock. C. Cardiogenic shock. D. Obstructive shock. Answer, B. Low SVR with normal/high CO is characteristic of distributive shock, as vasodilation dominates despite adequate cardiac output. Which medication is first line in neurogenic shock? A. Dopamine. B. Norepinephrine. C. Nitroglycerin. D. Furosemide. Answer, B. Neurogenic shock features vasodilation due to loss of sympathetic tone. Norepinephrine restores vascular tone and improves MAP. Which parameter directly measures left ventricular filling pressure? A. CVP. B. PAWP. C. MAP. D. HR. Answer, B. PAWP, via pulmonary artery catheter, reflects left atrial pressure and left ventricular preload, guiding fluid and vasopressor therapy. Which finding differentiates early versus late septic shock? A. Early, cool extremities, late, warm extremities. B. Early, warm extremities, late, cool extremities. C. Early, hypotension, late, hypertension. D. Early, bradycardia, late, tachycardia. Answer, B. Early septic shock often presents with warm extremities, vasodilation, while late shock shows cool, clammy extremities due to vasoconstriction and decompensation. A patient in hypovolemic shock is not responding to fluids. Which is the most appropriate next step? A. Continue fluids indefinitely. B. Consider blood products if hemorrhagic. C. Give vasodilators. D. Increase oxygen flow only. Answer, B. Persistent hypovolemia after crystalloids may indicate blood loss requiring transfusion to restore circulating volume and oxygen delivery. Which hemodynamic parameter is most useful to guide fluid resuscitation in shock? A. Heart rate. B. Stroke volume variation or dynamic preload measures. C. Respiratory rate. D. Oxygen saturation. Answer, B. Dynamic measures like stroke volume variation provide real-time assessment of fluid responsiveness, guiding safe resuscitation. Which complication is most likely with excessive fluid administration in cardiogenic shock? A. Hypotension. B. Pulmonary edema. C. Bradycardia. D. Hypothermia. Answer, B. Excess fluids and poor ventricular function increase hydrostatic pressure in pulmonary capillaries, leading to pulmonary edema. Which shock type is associated with bradycardia and hypotension despite normal CO? A. Septic. B. Hypovolemic. C. Neurogenic. D. Cardiogenic. Answer, C. Neurogenic shock results from sympathetic blockade. Bradycardia and hypotension occur even with adequate cardiac output. Which lab finding supports the diagnosis of shock? A. Low lactate. B. Elevated lactate. C. High bicarbonate. D. Low glucose. Answer, B. Elevated lactate reflects anaerobic metabolism due to inadequate tissue perfusion, supporting shock diagnosis and severity assessment. Which physical finding is typical of cardiogenic shock? A. Warm, flushed skin. B. Cool, clammy skin with pulmonary congestion. C. Dry, warm skin. D. Normal skin color. Answer, B. Poor cardiac output leads to vasoconstriction, cool, clammy skin, and pulmonary congestion due to elevated left-sided pressures.